So, hello, and today we continue the course of topographic neurology, and we will have a focus on sensory sphere today. By the way, if you have any questions related to your yesterday's topic, which was voluntary motion, please let me know. And if no, then without further preface, let's move on to our today's set of slides. So, somatosensory tracts. Why somatosensory? Because there are specific sensory tracts which are served by cranial nerves, and somatic sensation is all about bodily segmental sensation. And usually if you ask a neurologist how many senses we have, neurologist may answer at least 8, because in addition to 5 classical senses which are described, such as vision, hearing, auditory, gustatory, olfactory sensation, there is also sensation types provided by segments, by body, and here there are 3 flavors. Have a look, there are 3 types which we are going to discuss today. This means 3 tracts, because sensation is always a tract. There are a lot of synthetic senses like feeling of hunger, and here we speak about hardware. So 3 tracts: discriminative touch, which is responsible for superficial sensation, perception of pressure, vibration, texture, pain and temperature system, and proprioception, which is muscle flexion, extension sensation, actually providing us with body location sense. This is a refresher on axons, which are used because these 3 systems use different axon types, and sensory axons have classification according to their diameter and conduction velocity. Therefore, the largest and fastest is called A alpha, and it is used by proprioceptive neurons, while the second largest is A beta, and pain and temperature have the thinnest A delta and even non-myelinated C-type fiber. This is an ascending tract, so we're beginning the description not from the brain, we're starting from the peripheral portion, which is either nerve ending or a receptor, and from the nerve until the spinal column, until the dorsal root, these fibers follow together, and once they enter the spinal column via the dorsal root to the posterior horn. The fibers start sorting themselves out by diameter, and the largest enter the cord most medially, while the smallest enter most laterally. And from here, these 3 modalities, these 3 sensation types and tracts, take very different paths. So we need to look at each one separately. Let's start with discriminative touch. And this type relies on 4 different receptor types located in the skin. We're not going very deep into this formation, build up and their physiology, but what we need to know is that there are 2 main types, which are quickly responding and slowly responding. I have marked the quickly responding with red, while slowly responding are marked with regular color. And the reason, the good example for their response to stimuli would be that once the stimuli is applied, this type of corpuscles, which are fast responding, immediately start producing electrical stimuli, while Merkel's and Ruffinius endings don't do that. And if you, for example, sit on a chair for a prolonged period of time and stand up, you still feel the texture of the chair for a while, because these two types of slowly responding sensory bodies don't turn off immediately. They still produce electrical stimuli for a while. This is the wall tract. Possibly you may notice that there is the same legend, possibly, in topography, neurologic topography. Everywhere you notice that a neuron is always a massive dot, while a V-shaped connection is a synapse. And you may see that this is a 3-neuron pathway, unlike the pathway for voluntary motion, which has only 2. There are 3, and the first is located for both cases for every type of sensation in the dorsal root ganglion. And this is the primary neuron, and it has afferent part, which is different for upper and lower extremities. You see that there is a sorting of fiber size, and arm fibers are more lateral, leg fibers are more medial. You see that the primary afferents ascend all the way to the medulla on the ipsilateral side of the cord, on the same side of the cord within posterior columns. And this is an important aspect in the diagnostic, in localization of lesion, because other types of tracts, for example, may cross a different location more or less immediately, or do not cross at all. So by combining lesion types, you may localize the lesion. So they ascend on the same side, and the secondary afferents, the afferents of the second neuron in the caudal medulla, they do cross, and they ascend as the medial lemniscus formation. Lemniscus in Latin is loop, by the way, and you really see that they make a sort of looping in medulla. And later on, the only thing that the fiber has to do is to ascend to thalamus. And in thalamus, they synapse in the ventral-posterior lateral nucleus of the thalamus, and finally ascend to cortical analyzers, which we don't count here as a separate neuron, because cortical sensation is a different story. The next type of sensation modality is pain and temperature. And the difference here is, first of all, that it doesn't have a specialized receptor organ. No type of corpuscles or discs or other endings. It uses free nerve ending throughout skin, muscle, bones, connective tissue, wherever we need to feel pain or temperature. And as far as pain results from damage to free nerve ending, in reality this is a result of its interaction with damaged tissues. And once you damage the tissue, it starts releasing a massive array of pain mediators. First of all, that's prostaglandins, histamine, and substance P. And the nerve ending is trophic. It has receptors in some approach, but it's chemical receptors. It is trophic to these substances and let you know when the tissue is being damaged. It's a chemical process, and it's a small, very thin and non-myelinated fiber. For this reason, you don't feel pain immediately. As if you have a painful experience, you remember that the tissue is damaged, then a couple of seconds pass, and only then you experience pain. There are a lot of additional peculiarities here, and we will go through them now. This system, first of all, shares one major role with discriminative touch, primary afferents synapse ipsilaterally, and only secondary afferents do cross. Pin afferents enter the cord laterally because of their small size, and synapse more or less immediately. More or less because they actually travel up or down a couple of segments. And this portion is called Lizauer's tracts. It carries these migrating axons. And within one or two levels, they enter the dorsal horn and synapse. And their synapse in the dorsal horn is also dependent on various factors. First of all, look at the dorsal horn. It's a multi-layered structure. The outermost, the thinnest layer is called posterior marginalis layer, and the wide, pale second layer is called substantia gelatinosa, and the deepest is called nucleus proprius. There are two types of pain fibers. They enter different layers. Delta fibers, which are of myelinated type, enter posterior marginalis and nucleus proprius, innermost and outermost, and do synapse on a second set of neurons, as you see in the lower right portion of the screen. For delta fibers, the story is a bit more complicated. Delta fibers enter posterior marginalis, C fibers enter substantia gelatinosa, and they do not synapse on secondary afferents. They synapse on interneurons, an additional inclusive type of a neuron and its dendrite. In fact, this adds an additional part to the chain. And only through these interneurons there is interaction. This is, by the way, the whole tract. As you see, the main difference here is that the crossing, the decussation, is almost immediate, and this is a Lizauer tract in the bottom, and then the posterior column is being entered. And here in the dorsal column there is also a possibility of additional interneuron. Everything ends in the VPL, in the thalamus again, and this is the final point for all sensory tracts also. You should remember that thalamic nucleus is always the end point. So this is a schematic of all the pathway. This is not enough. There is also pain control subsystem, and we remember that if we experience pain, even the tissue is still damaged, it gets not so annoying after some time, because there is a pain control subsystem which uses endorphin interneuron or opiate interneuron, which is of inhibitory type. If you look to the right, you see that this second neuron, second order neuron, it has synapses with this descending opiate interneuron, which is projected from the midbrain. And in fact, this inhibition blocks further transmission of pain signals. And endorphin stands for endogenic morphine, and if it is synthetic, this is possibly the most potent painkiller. And finally, proprioceptive system, which first of all relies on receptors again in muscles and in joints. And these are muscle spindles and Golgi tendon organs. Just like cutaneous receptors, they have rapidly adapting, slowly adapting subtypes. And there are also Golgi tendon organs and joint afferents which monitor stresses and forces in tendons and joints. So muscles and joint flexion, extension, force, and stress. Interesting peculiarity in this tract is that it doesn't cross, mainly because it has a lot of interaction with cerebellum, which is its finally endpoint, which is its final receiver of its information, and cerebellum works on ipsilateral basis. Proprioceptive system arises from A alpha afferents. They travel a little bit with discriminative touch, and within a few segments, proprioceptive information slips out of dorsal white matter and synapses and continues without crossing to cerebellum. Exactly where they synapse depends upon the segment, either legs or arms being innervated. And leg fibers enter the cord at sacral or lumbar levels, ascend to the upper lumbar segments, and synapse in medial nucleus called Clark's nucleus. And its secondary afferents then enter dorsal spinous cerebellar tract on the lateral edge of the cord. Fibers from the arm enter the cervical levels and ascend to caudal medulla. And once they are there, they synapse with the external cuneate nucleus and then join the leg information in the dorsal spinous cerebellar tract. So this is topography. You see each type of sensory system has absolutely different type of topography, and what we have to do now is discuss sensory examination procedure. And it is also specific. It stands a bit aside from all other neurological examination, because here you cannot only trust yourself, you should rely on patient. And only patient reports you his or her sensory experience. You may remember possibly mute patients, demented patients, comatose patients, non-willing patients. And it is possibly the most difficult part of the exam, which is absolutely dependent on the patient's own impression. There are studies which give proof that patients with reactive depression, for example, report up to 40% stronger pain sensation. And pain sensation is measured by visual analog scale, which is in fact adjusted 10-grade ruler, where the patients point their level of pain. So if a regular patient shows 60%, 6 points on visual analog scale, patient with reactive depression of clinically significant level would point to 10. And there are a lot of other examples which demonstrate you that we should rely on patient, and we should think for the patient. Tests should be performed on all extremities. I would also say on all segments or on all levels, because of various possible locations. If you suspect, for example, a nerve lesion, and then you go through the nerve projection from the most distal to the most proximal part, for example, median nerve, and you start with the middle fingertip, and then you move up the phalanxes, the wrist, and upper. If you suspect a segmental loss, if you suspect spinal localization, you will have to compare dermatomes, which we studied yesterday. With cranial nerves, it's a similar story. There is different projection of cranial nerves plus specific sensation. That's a separate discussion. And if it is a central type of lesion, if it is post-stroke patient, then it will be hemi-type, hemi-distribution, or half of the body being involved. Plus, cortical sensation means involvement of cortical analyzers, which will produce not just loss of sensation, but deficits of analysis of this sensation. It's called high cortical deficit, and this is a matter for future slides today. Finally, we should exclude, even for healthy patient, we should exclude patient's judgment. And patient, even without any specific intention, may influence the results of the test by observing it, and so we should ask the patient to close or cover the eyes anyway. And this is a must. And concerning types of sensory modalities that we examine, we will speak about this right now. First of all, localization, we have mentioned that. Position and vibration sense. These senses ascend in the posterior column, so they will be manifested ipsilaterally anyway if patient experiences deficit of position and vibration sense. Then on the same side, cerebellum tests like finger to nose pointing tests will demonstrate insufficient productivity. On the other side, pain and temperature sense crosses quite shortly after entering the spinal cord, and almost any type of painful sensation will be carried contralaterally in the spinal cord, and as a result, it will be experienced contralaterally by contralateral hemisphere in the brain. Primary sensation deficits, these are types of sensation which are related to its decreased level, and these are usually deficits called hypoesthesia or anesthesia, decreased or lost sensation, and this is the most frequent type of sensory loss, very common among diabetic patients, for example, because at some point of time every diabetic patient develops peripheral angiopathy, and as a result peripheral neuropathy, starting with fingertips and resulting in gloves and stockings type of this sensory deficits distribution. This is a real symptom name, and it is called peripheral polyneuropathy. However, cortical lesions cause deficits which are not so simple, and there are a lot of them. We will pass to examination of high cortical sensation. Let's start with sensory modalities. First of all, very superficial discriminative touch sensation. We use, as it would be logical to guess, light touch. There are peculiarities again. This should be a well-chosen tool, because if we use just a needle, for example, this is not possible, because needle may be harmful for the patient. If we use a toothpick, it will not produce the same type of irritation all the time. So what can be done? This may be, first of all, a cotton tip. Light finger touch is only acceptable, not anymore, because if you want to measure the extent of sensory deficit for diabetic patient, you will not be able to do quantitative measurement. You can at least take a toothpick and bend it L-shaped form, so it looks like a little hatchet, like a little hammer. So this makes a better and more accurate dosage of stimuli all the time. For best results, you can use a thing called monofilament, and in fact this is just a plastic string which is certified to bend under specific pressure only. It is straight at 2 gram, 3 gram, 4 gram, but it bends at 5 gram. And for diabetic patients, there are even sets of monofilaments calibrated for different pressures. Temperature sensation, the easiest and acceptable bedside test is a cool piece of metal versus plastic. For example, your hammer, which has usually plastic and a metal part. A better way is tubes with water calibrated at different temperatures. This is already quantitative measurement, also good for diabetic patients. And possibly the best thing that I have seen is an electrically cooled and heated plates. There are types of electronics which produce exactly graduated heat or coolness, and there are two plates which patient touches, a hot plate and a cold plate, and there you can be precise to fractions of degree. Concerning temp vibration and proprioception, there are two options. It's a tuning fork, which you put to the desired location and compare to your sensation, presuming you have intact. And another option is gently bending, flexing, and extending the finger or the body part you want to measure. Not flexing, not bending, not holding it too firmly, because otherwise you will invoke superficial sensation pathway. The last thing I wanted to tell you is high order aspects of sensation, and they can only be tested if primary sensation is intact. If receptors are fine, then everything is delivered to the brain properly and therefore can be tested. But if initial part of the chain is broken, then brain anyway will not receive proper sensation, and you need intact peripheral sensation. High order aspects of sensation are found damaged in patients, of course, with cortical damage. If you see them, then most likely you have a patient with a cortical involvement. And there are a few examples. There are a lot of exotic, but quite a few useful clinical types. What is useful in the clinics? First of all, graphesthesia, and as a result, affected sensation is called agraphesthesia. We ask the patient to close their eyes and take a sharp and pointed object and ask patient to identify letters, numbers, symbols being traced on their palm or finger. This should not be something complicated. There should be X, 0, possibly line. Once I have seen student with a patient coming from rural area, from a distant village, and he was doing this type of high cortical sensory test, failing again and again. I asked him, what are you drawing? He told me omega. This should not be omega. This should be something really similar and understandable by a patient. Another one, which is useful, is called stereognosis. And this is a recognition of three-dimensional objects without assistance of other sensation. For example, a key or a pen, something that the patient has not seen in the beginning of the examination. You shouldn't show that to him or her. But then you ask to close the eyes, pass the object to the patient and ask, what's that? You should also comply with the patient's level of education and environment, because patient may be puzzled by a neurological hammer. This should be a pencil or a pen or a key. So this is it. There are also tests for tactile extension and double sensory stimuli. There is an effect that in patients with high cortical damage, removal of simultaneous stimulation from two sides is not experienced as a removal. They may still experience that. There are also tests which are associated with special senses. For example, for visual sensation, this will be neglect. A very surprising thing. A patient may see an object but not able to understand what's that. For example, in stroke patients, I have seen a story when a wife attended a post-stroke patient. From the left side, he could not recognize her. She was a new lady for him. And from the other side, she was familiar to him. This is an example of neglect. So, but this is totally reliant on special types of sensation. Well, it looks like that we have done quite fast today. Possibly material is quite bulky and insufficient. Anyway, but if you have any questions, please don't hesitate to ask. I hope you have enough to compensate this relatively short demo. Not at the moment. Okay. Anyway, I believe that you will develop questions, because an interested student always has questions. Thank you for watching. Thank you for coming. We will. The only thing I want to say that tomorrow, anyway, we start at 2 p.m. and this will be the topic on involuntary motion, or basal ganglion cerebellum. This is how it is called. The structure serving involuntary motor function, motor learning, and coordination. Something that is something that is absolutely required for normal voluntary motor activity. And for today, this is it. We're done. Thanks and goodbye. See you tomorrow.